So, talking about acute diabetic emergencies, we're going to hit the highlights, and anything that is not covered in this, I'm going to make sure that we go back and make sure that we understand it, because your national registry is very, very, very likely to have a pretty significant section on diabetes and diabetic emergencies. So you have on the NRMT, it's changed so that you have to basically treat a patient. You have to manage an entire scene. So you have before you arrive, when you're there, and then afterwards, your transporting phase. You're bringing them back to the hospital. We'll talk about it more later. I don't want to get too deep into it right now. But the reason I bring that up is because diabetes is such a common problem today that you are likely to get a scenario involving this. You need to know everything there is to know about it. All right, so what is diabetes? Okay, so it's a change in the mental status related to the alterations in the blood glucose level, the BGL, whether it's too high, hyper, or too low, hypo. All right, so under normal circumstances, our hormones control the blood glucose level. What organ is managing all that? The pancreas. What hormones are working there? Insulin. All right. So good. We got that. So I'm not going to go too deep into the how everything gets broken down here, because it's not that big a deal for you necessarily. We just need to know how we go about recognizing it and treating it. But here's an important thing: the brain cells can only use glucose for energy. They cannot function when the glucose is inadequate. So our patients that are hypoglycemic usually result in that altered mental status. All right. So, that's the next line. We're going to see problems in these patients that are hypoglycemic. That's when they are acting confused. They act like they're drunk. They have this slurred speech. They may not be oriented. All right. It may just be a matter of hypoglycemia. All right. So we talked about this a second ago. The pancreas secretes insulin. That's the hormone that is going to help regulate our blood sugar. Okay. Without insulin, little glucose can enter the cells. Think of it as a lock and key mechanism. Okay, here's more. There's also glucagon that can be secreted when blood glucose levels are extremely low, and you're gonna get into that a lot if you decide to go into paramedic school. You're gonna talk about how exactly that happens in the body. All right, some other hormones that are released are epinephrine. This is released when blood glucose levels are very low. All right, inhibits insulin secretion and promotes the release of stored glucose from the liver. The liver plays a very big function in leveling our and managing our blood glucose levels as well. All right, the normal range. Okay, so the book itself is inconsistent. So right here, we see the normal range of blood glucose levels is 70 to 120, but you'll see in these exact same slides later on, it's going to say 80 to 120. So should there be a test question, okay, asking what is the normal range, argue it. If you get it wrong, argue it, because you can show right back to these slides. So here, we see 70 to 120, but you're going to see later 80 to 120. So argue it if you get it wrong, if that is a test question. Say what? Yeah. All right. Boom, right here. Testing the blood glucose level with the glucometer. Normal readings from 80 to 120. Just a couple slides away. All right, so it says normal metabolism and glucose regulation, but the glucometer should read 80 to 120. That's confusing. It's too confusing. Argue it. If you see that problem. When interpreting the reading, determine the last time the patient ate or drank anything. The L in the sample, last oral intake. Okay, that can play a huge factor in what their glucose reading is. If you arrive on scene and you have a patient that has an altered mental status, and someone that knows the patient is giving them a Mountain Dew and they're drinking it, what might their glucose level be when you test it? It could be high or even just normal when you test it, but they were just having a hypoglycemic or diabetic emergency. All right, so taking into consideration what they last ate or drank and how long ago they ate or drank. All right, so hypoglycemia, we consider this a glucose level of 70 or less with signs or symptoms, okay? So you might test somebody's blood glucose level. It might be at 50, 60, which is pretty low, okay? But that might be normal for them, okay? If they're not exhibiting any signs or symptoms, that is normal for that patient. Okay, so it's only hypoglycemia if they're also exhibiting signs or symptoms. What are some signs and symptoms of hypoglycemia? Slurred speech, altered mental status. Okay, they're lethargic. Think of it, they're hypo. Okay, they have decreased blood glucose, or they have low vital signs. Okay, decreased respirations, low blood pressure. They might be pale, cool, clammy. Okay, this is where they're just slowing down. Hyperglycemia, we consider a glucose level of over 200. Okay, of over 200. We're going to talk about the different types of hyperglycemia in a second. All right, DM, you might see this. It just may be abbreviated as DM. That's diabetes mellitus. All right, this is just diabetes. Okay, you have type 1 and type 2. We're going to talk about those as well. All right, the patient has a high blood glucose level, but the cells are deprived of glucose. All right, so this is diabetes mellitus. The brain cells do not require insulin to use glucose, but we still need it in our bodies. Excess glucose is excreted by the kidneys, causing excessive water loss. So when we talk about the 3 Ps, what are the 3 Ps? It's the next slide, but we should know them. What are they? In layman's terms, if you don't know what they are medical terms, what are the 3 Ps? Excessive urination? Someone said it? Excessive hunger? Yes. Yes. Polydipsia, extreme thirst. Polyuria, excessive urination. Polyphagia, extreme hunger. Those of you that are in the med terminology class, when we talk about like phagocytes, okay, they eat other cells. Okay, polyphagia, extreme hunger. Polydipsia, thirst. Polyuria, frequent urination. You might get test questions, okay, that are just kind of describe these symptoms, okay, but they're not going to say extreme thirst, but your patient complains that he's gone to the bathroom 13 times today. He's also very, very hungry and thirsty. What might be wrong with him? Well, he's got probably diabetes. All right, in type 1 diabetes, the pancreas does not secrete insulin. Doesn't secrete insulin. So patients have to take insulin to regulate their blood glucose. These patients are prone to DKA. These patients are prone to DKA, and we're going to talk about that in a second. What does DKA stand for? Diabetic ketoacidosis. All right, so here's another concern of patients that are chronic insulin users. Chronic insulin users. I've responded to this call multiple times. You'll be at a clinic, okay, and they're at a clinic, surrounded by nurses and doctors, but they still call 911. It's taking them to a hospital, and the patient is acting altered. And the nurse will tell you, yeah, she has a history of diabetes, but she said she took her insulin this morning, so I don't know what's going on with her. Did she eat anything this morning? What is one common thing patients are told not to do before they go to the clinic or doctor in the morning? Eat or drink. Why? Because they're getting fasting labs. So they've been taking insulin every day of their life for God knows how many years. So they wake up, they're like, oh, I can't eat anything this morning, okay, because the doctor told me not to. But part of their routine is to take insulin. And what does insulin do? It's going to lower their blood glucose level, okay? Because the pancreas didn't secrete insulin, all right? So they need another method of getting it, and so they have to administer it themselves, and so they become hypoglycemic. All right, but type 2, these patients typically use an oral medication to manage it. For them, type 2 diabetics, they can oftentimes revert the effects of diabetes just by diet and exercise rather than insulin to manage. All right, but you'll get so used to seeing the same medications over and over again that you'll look at it and be like, all right, they're diabetic, they have hypertension, they likely had a stroke at some point. All right, so these patients are typically prone to HH&S. So type 1 is prone to what? DKA. Type 2, HH&S. And we're going to talk about the difference between these two in a second. Or if it doesn't, I'm going to go back and we're going to talk about it. So diabetics are prone to vascular disorders, okay? Vascular disorders, heart attacks, stroke. We already talked about stroke and what that does to your vascular system, okay? Kidney failure. A lot of diabetics have experienced kidney failure. So they need what? What do they need? Dialysis. All right, so in order to really accurately determine, you're going to need an A1C, okay, also known as the HbA1c. It's just an exam to determine, what your normal glucose level is. This is a test that's determined over a long period of time. Hypoglycemia typically occurs with type 1 diabetics, okay, results from excessive insulin that the patient takes to manage their diabetes. All right, so I don't know if we're going to talk about the signs and symptoms of DKA or HH&S, but we're about to right now. So what did we say, hyperglycemia, what did we say that started at? What BGL level? Over 200. So your patients that are in DKA, they are likely to exhibit signs and symptoms of what we would consider respiratory distress. Bless you. They're going to be breathing very deep and very fast. What are deep, fast respirations called? Deep, fast respirations. I know how to say it. I don't know how to spell it, so I'm looking it up right now. Starts with a K. It's called Kussmaul respirations. That is, write this down, Kussmaul. Kussmaul respirations. Those are fast and deep. Fast and deep respirations. Did Mr. Clear talk about this at all? He did. Perfect. Okay. So it's probably later on in the lecture, and then maybe we can skip past it. But I'm talking about it now so we don't forget to talk about it. So they're experiencing Kussmaul respirations. They may also have a fruity breath smell. What is that fruity breath smell called? Starts with a K. I think someone said it. Ketones. They're called ketones. Okay, that's that fruity breath smell. So they're breathing rapid and deep, and they have a fruity breath smell. Why? Why do they have a fruity breath smell? It's what? They're trying to burn off all that excess glucose, because they said that their DKA starts at what? 200, and what we say the normal was? Between 80 and 120. Okay, so they're hyperglycemic. They're trying to burn off that excess glucose. So an inexperienced EMT might see them and be like, wait a second, I know that the normal respirations are between what and what? 12 to 20? But let's say they're breathing at a rate of 26 and deep. So that's abnormal respirations, okay, out of those parameters. And deep, people aren't normally breathing very deeply. So what might an inexperienced EMT do? He might think he's under the influence of alcohol. Maybe he tries to start bagging him. Why would that not be a good idea to bag a patient in DKA? They're already trying to burn off the excess glucose, right? And they're doing that by breathing rapidly and deep. Now, if I start managing their airway for them, what am I doing to them? What's going to happen to their glucose level? It's going to go up. Okay? They're already trying to manage it naturally, not well, because they're in DKA. All right? But I'm not going to make it worse by bagging for them. So this is an example of where I have to be very aware of what is going on with the patient. I need to take in the entire picture here. Okay? Just because they're breathing in rapidly and deep at a rate of 26 or higher doesn't mean that I need to start bagging for these patients. Sometimes it does, okay? But here it doesn't. And especially if I smell that fruity breath, then what do we call that? Ketones. Especially if I smell ketones, I'm going to know, okay, they're in DKA. Don't start trying to think about bagging them, Sean. Don't do that. All right? Not a good idea. All right, so that we're still talking about hypo, because DKA is hyperglycemia, okay, but we're talking about hypoglycemia. And I'm going to talk about HH&S in a little bit later. So, hypoglycemia. So the patient takes insulin but doesn't eat a meal. Like I just said in that example, the little old lady that goes to the clinic. Patient that takes insulin eats a meal but drastically increases the activity. Why would that affect it? Because what does the glucose do? It provides what? Energy. And they increase their activity. It's going to affect their bodies. The patient takes too much insulin. Okay? So here we have the problem where a patient, let's say they're older and they have Alzheimer's and they're managing their medication. Maybe they just have dementia and they're still managing their medication. They might take their insulin, forget, come back and do what? Take it again. All right? This can also happen in type 2 diabetics if they take too much of their oral medications. So we might see altered mental status in these patients, okay? As the glucose level drops, epinephrine is secreted, okay, at higher levels to shut down the secretion of insulin and stimulate the excretion of glucagon. Glucagon comes from the what organ? The what? Nope. What was the other organ that we said?
Liver.
The liver. All right, so now the liver's getting involved. And it's trying to do its best, but it can only do so much. All right, so some signs and symptoms: confusion, disorientation, drowsiness. These patients are slowing down. Hypo, we're going low, we're getting low. Stroke-like symptoms. What did I say earlier? A stroke isn't a stroke until we rule out what? Low blood sugar. But we're EMTs, we don't call it low blood sugar. Hypoglycemia, okay? We might also have seizures. We can have seizure involvement in hypoglycemic patients. All right, so over time, signs and symptoms of hypoglycemia can change. This is typically over a very long period of time. All right, so we need to break them down into two categories here. Can they swallow or can't they swallow? If my patient can swallow and can follow commands, what can I give them? Oral glucose. How much? Half or whole tube. All right? But if they cannot follow commands or cannot swallow, what do I not do? I don't put anything in their mouth. Okay? I've gone to these clinics and had these nurses be like, well, I put Skittles in her mouth. Like, lady, she's drooling. Okay, she obviously cannot swallow. Get that out of her mouth, okay? And we're going to treat her a different way. All right, you're going to kill this woman. All right? Just like in any field, not everybody's great at their job. Okay, so let's say you have that patient that cannot follow commands. Who might what you want to call? ALS. Why? Because we can give an IV and we can give what? Dextrose. Sugar water. All right? It's one of the easiest things as a paramedic to resolve. Okay? That's the calls you want to get that are super simple. Like, all right, altered mental status. Oh God, this could be anything. Oh, they're diabetic? Yeah, I got you. Okay, ensure patent airway. All right. Administer or assess their glucose level and administer a tube of oral glucose. All right, it's absorbed quickly. All right. So is that a long-term solution? No. What are you going to recommend to your patient if they refuse to go to the hospital? All right, example time. All right, you have a patient that is altered. You test their glucose level. It is in the 40s. They're able to follow commands. They're able to swallow. You give them oral glucose. You're in the back of the truck. 5 minutes later, they start coming around. They say, "Where am I?" You say, "Sir, ma'am, we're in the back of the ambulance. We're going to Providence or Hillcrest." And they say, "Nope. I want to get out. I want out. I want out right now." What do you have to do? Reevaluate the mental status, ensure they're competent. So you ask them questions. Are you orientated? Okay. Who's the president? What day is it? Where are you? What was the last major holiday? I have 4 quarters in the nickel. How much money do I have? They're able to answer all your questions. They're A&O times 4. Can I hold them? No. What am I doing if I do hold them? I'm kidnapping them. So I let them out. Okay. I'm going to try to get them to sign a refusal, but what should I recommend the patient do? I'm going to recommend they go to the hospital. If they absolutely refuse, and all I've given them is oral glucose, what do they need to do? They need to eat. They need to eat something. So here's an example of administering it. Okay, she's just squirting it inside the cheek, or you can squirt it on a tongue depressor if you don't want to do that, and you just place it on the cheek. What is that called? Buccal.
So if you were to only do half the tube, how would you go about, like, would you just throw that away after since you inserted it in the mouth?
Yeah, it's gonna get thrown away, but I can at least give them half a tube, reassess, give them the other half if necessary. See what I got going on? All right, glucagon does not contain glucose. Okay, glucagon converts glycogen in the liver to glucose. So how do we administer that? This is done using a mucosal atomization device. This is not taught in EMT, but some EMTs are allowed to do this. It is a syringe that has a device on top of it. There used to be one in here. So this is a MAD, okay, mucosal atomization device. Okay, some people call it MAD device, but that makes me very upset. So this is what we use, and we insert into each nostril. Half the medication in one, half the medication in the other. You might also administer Narcan this way. All right, but again, it's not taught here in this EMT program, but some EMTs are allowed to do it. So if you are, obviously, get familiar with your protocols and follow that. Hyperglycemia. So we talked about DKA already. So we feel pretty confident in that? All right, so we said hyperglycemia is excess of 200. DKA characterized when we go over 250. So we have the presence of ketones. What did we say ketones were? The fruity smell. HH&S is when we are continuing to skyrocket. Our glucose level is going up and up and up and up and up, and we're over 600. Okay? We're looking at the 600s. Both of them are medical emergencies, and they need to be seen by a physician. All right, so without insulin to help glucose move into cells, the cells are starved, so the cells begin to burn fat. Cells begin to burn fat. So you guys have ever heard of the keto diet? All right, same thing. You're trying to trick your body into that state. Factors that can lead to DKA: infection or sepsis, inadequate insulin dose. Different medications can cause it. Stress, increase in carbohydrates. All right, these are all things. DKA signs and symptoms are produced primarily by the dehydration and buildup and acid buildup. So we're moving to let's say they're also having difficulty breathing. We're going from an aerobic to an anaerobic state. What's a byproduct of the anaerobic state? A buildup of lactic acid. Nailing it. All right, so those 3 P's, what did we say they were? Polydipsia, polyphagia, and polyuria. Which one's excessive urination? Polyuria. Excessive hunger? Polyphagia. And then lastly, excessive thirst is polydipsia. Okay, they may have nausea, vomiting, muscle cramps, okay, due to electrolyte imbalances. So that loss of potassium, sodium, and magnesium, these can all cause that. What's a food that we can eat that's high in natural sugars and has a lot of potassium? Bananas. All right, how do we manage DKA? Okay, PPV if needed. Okay, but you got to be so careful about this because if the patient is trying to burn off their excess glucose, okay, we don't really want to interrupt that. The only time that I'm going to be like, okay, I know my patients in DKA, they have Kussmaul respirations, and I smell ketones. The only time I'm going to interrupt that is if they are now showing signs of respiratory distress. Like they have, what are some signs of respiratory distress? Cyanosis. That'd be a big one, okay? Oh my God, he's now cyanotic. All right, what his body's doing isn't working, so I'm just going to have to intervene. All right, pathophysiology of HHS, okay? We're really talking about HHS here. Blood glucose levels is 600, but could be all the way up to 1200 or even higher. Your little device may only say high. It might not even read the level that it's at. So what do we do for these patients? We need to give them oxygen, okay, and rapidly transport. Oxygen and rapidly transport. Because there's nothing that we can really do. So with HHS, there's no buildup of ketones in the body. All right? There's no buildup of ketones. That means we're not going to have that fruity odor. And Kussmaul respirations, what's the definition again? Rapid and deep respirations. Sure they have patent airway, provide O2, and get them out of there. Frequently check their glucose level. Okay? Frequently check their glucose level. Let's talk about onset. Hyperglycemia. Is it rapid or slow? Hyperglycemia, rapid or slow onset? A very slow onset. Hypoglycemia, very rapid onset. Very rapid onset. So here's just an example of what different levels can do. All right, basic care, supportive. All right, so we're talking about DKA, not a lot we can do. When we say supportive, like we were talking about before, providing oxygen to them. So I might maybe give them a non-rebreather, but I'm probably not going to start breathing for them, even if their respirations are over 26. ALS, like we're talking about, we can administer fluids to these guys, and we can give them IV glucose or dextrose. Or if necessary, we can administer glucagon. These bracelets are always a good indicator to alert to any type of medical conditions. Insulin pumps, okay, yeah, it's going to be a pretty big, no-brainer there. Should be able to figure it out. Any type of altered mental status, always ask, what question? Do you have a history of diabetes? It's so common, that should be a question you ask just about everybody. Or they're probably going to tell you. If they do say, yes, I have diabetes, ask what meds they're on, when was the last time they ate, and any change in their activity, because we said that can cause complications as well. Here, you have somebody that has an insulin dependent diabetic. So this is they may have a pump, but you also have, what am I trying to say? You also have glucometers that don't have to directly interact with the patient. That is, they have a device that's implanted in them, and it just sends that information to a machine. Okay? Sends that information to a machine. Here's a patient that is exhibiting signs and symptoms of, what do you think, hyper or hypo with this patient? Why hypo? They're lethargic. She's pale. And what do we call pale? What's that word called? Pallor. She's exhibiting signs of pallor. Rapid onset. Okay? And that tachycardia, okay? What is tachycardia? Rapid heart rate. Because epinephrine is being released. What does epi do? Elevates the heart rate. Okay? Because it's going to start stimulating the liver. All right, elderly patients frequently suffer from signs and symptoms that mimic a stroke, but I said multiple times, a stroke is not a stroke until we rule out hypoglycemia. Maintain the airway, ventilate if necessary, oxygenate if necessary. If they can swallow, this is hypo, and they have low glucose, administer oral glucose and transport. All right, that's about it.